My name is John Foreman. I work at the Brigham Women's Hospital. I also work at Up to Date, where I'm a deputy editor of nephrology. And today I'm going to be talking about both the basics of hypertension and treatment, and also resistant hypertension and common forms of secondary hypertension. I may just go from one into the next, depending on the time. So here's my disclosure slide. I work at Up to Date, which is a division of Wolters Kluwer Health, and I work there as a deputy editor of nephrology, and I will be referring occasionally to Up to Date. So the first topic I want to hit on this morning is how to diagnose hypertension in 2016. And diagnosis of hypertension seems like a run-of-the-mill subject, but it's changed a bit, and there are new recommendations which have been published by the Canadians and by the US within the last 6 months, which have impacted how we are supposed to, maybe not as nephrologists, but if any of us have primary care clinics as well, how we are supposed to be diagnosing hypertension. So before I do, I just want to present a case, and I know we don't have the audience response system, so a show of hands would be fine, or just shouting out what you think the answer is. So a 45-year-old asymptomatic woman presents to established care after not seeking medical care for 10 years. The medical assistant measures her blood pressure using the wall cuff and the oscillatory method, and obtains a blood pressure of 155/96. Notably, both of her parents had hypertension, and her exam is otherwise normal. So which of the following is the most appropriate next step? Should we diagnose her with hypertension and start treating her? Schedule a return visit where we measure it again with the wall cuff and initiate therapy if it's high then? Or should we perform 24-hour ambulatory blood pressure if feasible, or have her check her home blood pressure if 24-hour monitoring is not feasible? Or should we measure her blood pressure in the clinic with an automated oscillometric device, and if high, initiate therapy? So which of those is the most appropriate next step? C, absolutely. Okay, so options for measuring blood pressure: there's ambulatory monitoring, which you're all familiar with, takes blood pressure every 20 to 30 minutes during the day, depending on how you program it, every hour at night. Or you could perform home blood pressure, and the current recommendations for home blood pressure are to have your patient, in the diagnosis of hypertension, have your patient measure their blood pressure twice a day, morning, evening, for a week. Discard the first days of measurements, so then you have 12 that you can average together, and that would be your home blood pressure. Then there's clinic blood pressure, and there are two ways to do clinic blood pressure. There's the routine clinic blood pressure, which is done in most clinics with using auscultation, and then there's the automated oscillometric devices, and these come in a variety of flavors. There are devices that some of you may be using that are programmable so that they can take the blood pressure multiple times and create an average blood pressure without a medical assistant or without you in the room, where you push the button, you step out, blood pressure is automatically taken. This is the type of, and these automated devices are the types of monitors that were used in some large trials that were done recently, most notably SPRINT, which I'll talk about, but also the ACCORD trial, which was published a handful of years ago. We're using these automated blood pressures where the blood pressure could be taken with nobody in the room with the patient. And this is important because it tends to read lower than if you are taking the blood pressure yourself, or your medical assistant's taking the blood pressure, or if you use one of these automated devices while you're standing there or sitting there in front of the patient. And it more closely approximates what you would get with home blood pressure or with ambulatory blood pressure. So ambulatory blood pressure, again, this is just review, you all know this, is a much better predictor of outcome than clinic blood pressure. These are various cardiovascular outcomes listed on the left, and this is a meta-analysis of the predictive ability of hypertension defined by ambulatory blood pressure after controlling for clinic blood pressure. So ambulatory hypertension is a much better predictor of outcome than clinic hypertension. And the same goes for home. So this is a meta-analysis of home blood pressure after controlling for clinic blood pressure, and again, a much better predictor of cardiovascular events and death. And clinic blood pressure is frequently not confirmed when you follow it up with out-of-office readings, either with ambulatory blood pressure at the top or with home blood pressure at the bottom. The range for confirmation of an elevated clinic reading in these various studies was from 35% to 95%. So a very high possibility that the hypertension diagnosed in the clinic is actually not present at home. And this has led two major organizations, the United States Preventive Services Task Force and the Canadian Hypertension Education Program, to recommend that people not be diagnosed with hypertension until blood pressure is measured outside of the clinic. So this is their recommendation, that if you have a high clinic reading, you should follow up with ambulatory blood pressure monitoring, if that's feasible, insurance, if it's available, and if not, to perform home blood pressure monitoring as a means of confirming hypertension. The Canadians agree with the US PSTF, but also say that if you're going to measure, and this is a change that's happening in a lot of clinics, I don't know if it's happening in your clinic, but that for office measurements, instead of using the standard way that most of us are used to use these automated devices that will take the blood pressure while nobody is in the room with the patient. So the Canadians created a guideline, an algorithm which is also modified and is up to date, and I'm just going to try and summarize it here. If you have an office blood pressure that's high, and either standard measurement greater than 140/90, or using one of these automated machines greater than 135/85, because blood pressure tends to be lower. If it's very, very high, or the patient has hypertensive emergency, they have hypertension. If not, then you need to confirm with out-of-office measurements, ambulatory blood pressure if possible. The definition of hypertension by ambulatory blood pressure is a 24-hour average greater than 130/80, or a daytime average greater than 135/85. And this is also this daytime average for ambulatory is the same definition for using home monitoring. If you can't do ambulatory, then you need to do home blood pressure monitoring. There's actually a recommendation to do home blood pressure monitoring twice, so over 2 weeks. And if the home blood pressure is high, it's hypertension. If not, white coat hypertension. Now, if you have to do it in the clinic, the recommendation is to do it an additional 3 times after your initial clinic visit where the blood pressure was high. And the reason is because studies have shown that over time, with multiple clinic visits, the blood pressure successively drops in the clinic. Now, there are exceptions to this, so that if the blood pressure is high on the second time you see them in the office and they have evidence of target organ damage, or they have diabetes or chronic kidney disease, then treating them for hypertension is reasonable at that point. If not, but they have stage 2 hypertension, 160/100 on the third office visit, treating them at that point is reasonable. If not, if they have mild hypertension, no target organ damage, no comorbidities, then the suggestion is to not diagnose hypertension using clinic blood pressures only until you've had 4 office visits where you measure their blood pressure. So just to summarize, in 2016, we're now being advised to measure blood pressure outside of the office using ambulatory if possible, home if not possible. And if you're going to use office visits, you have to do it, depending on the comorbidities and other things, you really need to do it multiple times before committing your patient to therapy. All right, so this is going to be the most controversial / contentious part of the talk. 53-year-old man returns for follow-up of his hypertension, which you diagnosed 6 months ago. He's currently taking lisinopril to control his blood pressure, no adverse effects. He smokes a pack a day, his cholesterol is 254, his HDL is 31. He doesn't have diabetes or CKD or known cardiovascular disease, but you calculate his 10-year Framingham risk score, and it's greater than 30%. So his blood pressure today is 138/81, taken by the medical assistant using oscillatory method. And the question is, which of the following is the most appropriate next steps to manage his hypertension? A, he's at goal, no further intervention needed. B, intensify his regimen with a goal clinic systolic blood pressure less than 130. Or intensify his antihypertension intensive regimen with a goal clinic systolic blood pressure, again using your oscillatory method, which you use in your clinic, to a blood pressure of less than 120. Who's for A? And B? And C? Okay. Most abstaining. All right, so before we get into a discussion of goal blood pressure, I just want to state that reasonable and intelligent people can disagree and do disagree about what goal blood pressure is. There are many guidelines. They don't all say the same thing, and I'll show you a list of guidelines that don't necessarily agree with each other. In the US, most people think of JNC. In Europe, it's the European Society of Hypertension. So there are guidelines, and in Canada, it's CHEP. So lots of guidelines out there, and a lot of them say different things. One thing to keep in mind about the guidelines is that the data that's considered in a published guideline is often 3 to 4 years out of date. For example, the American Heart Association hasn't produced guidelines on goal blood pressure for 5 years. And the two that are updated the most frequently, the official Canadian Hypertension Education Program is revised annually. So there's a new publication every year from them, and then Up to Date, which is revised continuously. So this is what I meant by lots of guidelines being out there. So the American Heart Association, in conjunction with the American College of Cardiology, American Society and International Societies of Hypertension, the British guidelines, the European guidelines, JNC8, which I put in quotes because we'll talk about that in a second, SHEP, and then there are specific guidelines in kidney disease, KDIGO, and for African Americans. And as you can see, there are a lot of different goals. If you look at SHEP, which was just updated for 2016, they've added a new guideline for people at high cardiovascular risk. So the reason I just want to take a diversion into JNC, because in the US, this is what most people look to for guidance on how to manage blood pressure. JNC 7 was in 2003 and had goals of less than 140/90 for most people, which hadn't changed since 1984, and goals that were lower, less than 130/80 for people with significant comorbidities. And the American Heart Association years later agreed, adding that people with high cardiovascular risk should be included in this comorbid group who needed a lower goal. And then JNC8 came out a few years ago, removing the lower goal for high-risk people and also raising the goal to 150/90 for people over the age of 60. So this was the major change that happened in 2013, but JNC really wasn't JNC. So the Joint National Commission is empowered by the NHLBI, the NIH, to make recommendations for blood pressure, and they appointed this committee of 48 members in 2008, and most people on the committee left. Presumably because of dissent, and a few were added, and the final panel included 17 members. And eventually, NIH said, we're no longer associated with this panel. The AHA, the ACC, and the ASH, which also tend to be involved in these guidelines in the past, also disavowed themselves from JNC. And one thing to keep in mind is that adopting a new guideline in JNC8 required a 2/3 majority, so 12 people had to agree. And the change in older individuals from a systolic less than 140 to a systolic less than 150 was a vote of 12 to 5, so had one person not voted for but voted against changing the goal from JNC would not have changed. Okay, so let's talk about what the evidence suggests should be the goal blood pressure. So observational studies we could look at of attained blood pressure, but there's bias associated with observational studies. You can look at randomized trials where you have somebody whose blood pressure is already below a certain level, such as 140/90, and then randomize them to placebo or to medical therapy. And if medical therapy is better, that suggests that a lower blood pressure is better. Or you could have the gold standard study where you actually shoot for one goal versus another goal. So most studies have been in patients with high cardiovascular risk, and this is where most of the interest is. SPRINT defined high cardiovascular risk as people with existing cardiovascular disease, people with chronic kidney disease, those over the age of 75, or those with a Framingham risk score greater than 15%. Other high-risk populations that SPRINT did not consider were patients who've had a stroke and diabetic patients, and the reason that those people were excluded from SPRINT is not because the investigators were not interested in lowering blood pressure in those individuals, but specifically because it was an NHLBI-sponsored study, and NHLBI sponsored 2 other studies using similar methodology in stroke patients. That was the SPSS trial, which was published a year or so ago, and then in diabetic patients was the ACCORD study. So NHLBI wanted to do these 3 separate large trials. So This isn't SPRINT, these aren't goal blood pressure trials. This is a meta-analysis that asks the question, if you take people at high cardiovascular risk, regardless of why, existing cardiovascular disease, diabetes, and you take only the people from those trials whose blood pressure was already less than 140/90, and then you randomly assign them to receive an antihypertensive medication or placebo, does putting them on an antihypertensive medication produce benefit? And there are lots of these meta-analyses, and this just happens to be one, but they all basically say the same thing because they're all looking at the same trials. And what you can see here is that if you take people whose blood pressure is less than 140, who are at high cardiovascular risk, and you add an additional antihypertensive medication, it's associated with lower cardiovascular disease and lower mortality. So this suggests that the goal should be somewhere below 140 for people at high cardiovascular risk. The best way to do this is with goal blood pressure trials. The blue are people high cardiovascular risk, orange is diabetes, green is stroke, and yellow is chronic kidney disease. But there are a lot of these studies, and there was a meta-analysis of 19 trials and 45,000 patients. Now, problems with this meta-analysis, which was published just earlier this year, is that it did not include SPRINT. And it also included a number of trials that looked at different goals. So 140 versus 120, 150 versus 130, 170 versus 150. So there were a lot of different goals here. Although Cohort is here, SPRINT is not here. But regardless, going for the lower goal tended to produce better outcomes than going for the higher goal. It wasn't significant for mortality, but it was significant for stroke, MI, and major cardiovascular events. So far, like I said just a second ago, more intensive control seems to be better in patients at high cardiovascular risk. It should be somewhere less than 140/90, but it's not exactly clear where. So the biggest trials that were done where the goals were actually achieved were the Accord study, which is in diabetics, about 5,000 diabetics, and the SPRINT study, which you're familiar with, just came out recently in November. So SPRINT, as you know, multi-center open-label trial, more than 9,000 patients who had high cardiovascular risk and hypertension. People with stroke, diabetes, and proteinuric chronic kidney disease were excluded. And although it did include a large population with chronic kidney disease, the treatments were a systolic goal less than 120 versus less than 140, and importantly, the method of measuring blood pressure in this trial was not the standard cuff. It wasn't having somebody being in front of the patient and having the blood pressure checked 3 times. It was putting the patient, the participant, I should say, in a room using one of these automated devices where the blood pressure was averaged multiple times while they were alone. So that's very important to keep in mind, and that comes into play when discussing goals. It was stopped for benefit at 3.3 years. There was a combined cardiovascular endpoint, which was the primary endpoint. And then Accord almost had exactly the same methodology. So the patients were obviously different. They were diabetics. There were age qualifications depending on whether or not you had existing chronic cardiovascular disease or suspected cardiovascular disease. Same goals and the same method of measuring blood pressure. The difference here is that this was a 2x2 trial, and we'll get into that in a little bit. They used a composite cardiovascular endpoint, just like SPRINT, although it was slightly different composite cardiovascular endpoint. So like I said, both of these trials did a very good job achieving the goals. Sort of. So SPRINT, most people did not achieve a blood pressure less than 120. The average was 121 in the intensive arm, and most people were requiring 3 medications. Accord did achieve an average blood pressure of 119. But basically, both trials did a very good job. So here are the results side by side. So SPRINT was labeled as a positive trial because major CV events, which was the primary endpoint, were significant in favor of a lower blood pressure. Accord was billed as a null trial, suggesting that diabetics should not have a more intensive goal because major CV events, which was the primary endpoint, missed statistical significance. There was tended to be an improvement, but the confidence intervals go up to 1.06, so this was a null trial. But as you can see, if you look at this, they tend to all these outcomes, except for mortality in Accord, which I'll talk about, tend to line up towards benefit with lower goals in both diabetics and in non-diabetics with high cardiovascular risk. There are obviously adverse outcomes associated with shooting for a lower goal. So in both studies, higher rates of electrolyte abnormalities, higher rate of syncope in sprint, but not in accord, and a rise in serum creatinine was very common with lowering the blood pressures you see on a daily basis in your practice. So if you combine sprint and accord into a meta-analysis, and this was part of the editorial that accompanied sprint, if your eyes just go to the bottom where it says combined, this is the primary outcome is defined, this is the combined cardiovascular outcome. Intensive treatment, and again, same goal in both trials, same method of measurement in both trials, was associated with a significant benefit, suggesting maybe accord wasn't null. So accord actually wasn't null. Well, I mean, you could argue about whether accord was null. So accord was a 2-by-2 trial. So everybody was assigned to one of two blood pressure goals and also to one of two A1C goals. So one of the arms, the A1C arm, had people less than 7% in one arm and less than 7% in one arm. Standard goal was 7 to 7.9, and the other one was less than 6%. So overall, CV events were not reduced and death was not reduced with intensive blood pressure. But there was an unexpected power issue here, and that the issue here is that if you do a 2-by-2 trial, you're assuming, or most people assume, that you are not going to have a statistical interaction between this intervention and that intervention, that they will have independent effects. But in fact, they did not have independent effects because the people that were on the lower A1C goal of less than 6% and on the more intensive blood pressure actually had a higher mortality rate. But if you look at people who were in the standard glycemic control arm, lower blood pressure goal reduced the risk of cardiovascular events and had a trend towards a decreased risk of death. So there was a significant interaction, and when there's a significant interaction in a study, you tend to present the results separately according to subgroup. But the main overall trial was billed as being null. So for goal blood pressure in people with high cardiovascular risk, we know that additional therapy is beneficial in patients who already have blood pressure less than 140/90. Targeting a blood pressure less than 120 versus less than 140 reduces mortality and cardiovascular events at the trade-off of higher serum creatinine, electrolyte abnormalities, and syncope. And the question then is, do you agree with the statement that goal blood pressure should be less than 120 in patients at high cardiovascular risk? Who says yes? Who says no? Okay. So one of the points here is that it really matters how you measure the blood pressure. So, like I said, in these trials, the automated oscillometric BP was done, and this is a better approximation of what you'd get with ambulatory monitoring and with home blood pressure monitoring. You get about a 5 to 10 millimeter higher reading typically, and again, there's variability here, but if you look at the conglomerate of the data, it's about 5 to 10 millimeters higher with the conventional methods. So perhaps goal blood pressure should depend upon how you're measuring the blood pressure. So if you look at sprint, the intensive group achieved a systolic blood pressure of about 120 to 125 with the automated machine and required about 3 medications. So using that data, the goal blood pressure in patients who are at high cardiovascular risk, people who would meet criteria for sprint, and the Canadians have adopted this. This is up to date. It has not yet reached other guidelines, but other guidelines haven't been published yet. If you're using one of these automated machines, goal blood pressure, it would be reasonable to shoot for a goal blood pressure and high cardiovascular risk of 120 to 125. If you're using standard methodology to measure blood pressure, 125 to 130. Now, remember when I put up the slide about JNC7 and the American Heart Association guidelines that agreed, they were suggesting a goal blood pressure less than 130 for people at high cardiovascular risk. So now we've come back to where we were 13 years ago, and now recommending a goal blood pressure less than 130 in people with high cardiovascular risk, diabetes, chronic kidney disease. So using this range, permits some leeway, and also if you make a recommendation to go less than 120, that could mean 90, that could mean 100 for systolic or 110. And that might, there's controversy about the J curve, but that might not be such a good thing. Okay, so I just want to then, because we're all nephrologists, talk about goal blood pressure and chronic kidney disease. We're going to come back to the similar conclusion that we just reached for high cardiovascular disease. But we have 4 trials of goal blood pressure in patients with chronic kidney disease. The oldest was the MDRD trial, the RAIN2 trial, the ASK trial, and then SPRINT, which we just talked about, was the largest by far. So MDRD was a multi-center trial of 840 people with chronic kidney disease. There were basically 2 studies, A and B, depending on the GFR of the participants. And the goal blood pressure also depended upon age, but was 125/75 roughly versus 140/90 for people who were age less than 60, and if you were older, the goals were slightly higher, 130, 150/95. So the mean follow-up was 2.2 years. These are renal endpoints. So, and this was only during the trial phase, because they followed them for 2.2 years, but then they followed them longer in a post-trial cohort phase, which I'll talk about in a second. But this is just the trial phase. So the lower blood pressure goal was associated with a slower rate of GFR decline than the higher goal. And the risk of ESRD was not significant, but there was a trend towards favoring the lower blood pressure goal during the trial phase. So if you then tack on the cohort phase, the risk of end-stage renal disease with the lower goal was significantly lower than the risk among patients who were randomized to the higher goal. And death or end-stage renal disease, the composite endpoint, there was also a benefit, if you look at the cohort phase, associated with the lower blood pressure goal. This notably varied according to proteinuria. So if you look at the left, the people at the top have no proteinuria, a protein creatinine ratio less than 3 or less than 300 milligrams per day. And then the people at the bottom have more than 3 grams a day. So what you see here is that the more proteinuria the individual has, the more they benefited in terms of end-stage renal disease risk and end-stage renal disease or death, the more they benefited from having a lower blood pressure goal. The RAIN2 trial, I'm not going to spend much time on, was a group of individuals with proteinuric chronic kidney disease, 338 patients, and they were randomly assigned after receiving ACE inhibitors to a drug or to placebo with the goal of having blood pressure be lower in the group receiving therapy. And this is if you look at the axes, what you can see here is that the 2 goals are, the 2 groups basically achieved the same blood pressure. Intensive control had a blood pressure that was a few millimeters of mercury lower than the conventional arm. So the goals here were not achieved. There was no difference in endpoint. The ASK trial was a 3/2 factorial trial, but essentially one of them was a goal blood pressure aspect of the trial, where blood pressure was, the aim in the lower arm was 125/75 or less, and the aim in the higher arm was 135 to 140. And they were followed for 4 years, as well as a post-trial follow-up that went out to 12 years. And as you can see, there was no difference there was a significant difference, I should say, in systolic and diastolic blood pressure during the trial phase, and they came together during the cohort phase. So if you look at the trial phase, the risk of end-stage renal disease and death was not significantly lower. It was a trend, but not significantly lower, favoring the lower blood pressure goal. If you look at the trial plus the cohort phase, again, this was not significant. The confidence intervals cross 1, but again, a trend towards a lower blood pressure goal being of benefit. Just like in MDRD, this varied according to proteinuria. So individuals with proteinuria, there was a benefit to a lower blood pressure, whereas this was not the case in patients without proteinuria. So if you take all of these trials and look at them together, and you look at the risk of end-stage renal disease or death, and in SPRINT, this is really death, because in SPRINT there were very few end-stage renal disease events. RAIN is the one that appears to be where lower goal blood pressure does not appear to be a benefit, but again, the separation in blood pressure was only 4 millimeters of mercury in that trial. If you look at MDRD, ASK, and SPRINT, basically shooting for a lower goal was of appear to be of benefit. In SPRINT, these people did not have proteinuria. In ASK and in MDRD, patients did have proteinuria. So to summarize goal blood pressure trials in CKD, they for the most part agree with the goal blood pressure trials in people without CKD and high cardiovascular risk. All right, next case. 53-year-old man returns for follow-up of his hypertension, which you diagnosed 6 months ago. He's currently taking lisinopril. Oh, so sorry. This was the answer. Case 3, 53-year-old man returns for follow-up, which you diagnosed. So the same thing, except his Framingham risk score is 7% instead of greater than 30%. And today his blood pressure is 138/81, taken by the medical assistant using auscultation and a manual cuff, which is what you use in your office. So in this patient who, unlike the previous patient, does not have high cardiovascular risk, which of the following is the most appropriate next step? A is blood pressures at goal. B, intensify his regimen and get him to less than 130, or C, intensify his regimen with a goal blood pressure of less than 120. Okay, so before going to the answer, I just want to take a digression into some statistics. And the way things tend to work with, in clinical trials and in medicine is that interventions that beneficial interventions will tend to have a similar relative risk no matter which patient population you study. High risk, moderate risk, and low risk. Treatments tend to have similar relative risks, but the absolute risks are going to be very different and are going to depend upon how the baseline risk of the population, and that's really what patients care about. Patients don't care about relative risk, patients care about absolute risk. So here's just an example, hypothetical example. So say your therapy produces a 33% relative risk reduction, which looks very impressive, and that's usually what's presented in research papers. So if you have a high risk group where the baseline risk is 30% of having a bad event, you've created a 10% absolute risk reduction. You're 10% less likely to have that event. If you take a moderate risk group, or if you go all the way to the right to the low risk group, where say only 3% of people will have an event, you have this very impressive relative risk reduction of 33%, but really the absolute risk reduction is only 1%, and if you look at the number needed to treat, if the number needed to treat over on the left is very low and the number needed to treat on the right is very high, assuming that side effects are the same and so therefore the number needed to harm is going to be the same, then you would argue, well, we should do it in the high risk population but not do it in the low risk population. Hope that makes sense. So this is applicable to why there ought to be different goals for a high-risk population and a low-risk population when it comes to blood pressure. So the relative benefit tends to be the same from lowering blood pressure, and I'm going to show you an example of that in just a second, but the absolute benefits are going to vary according to your baseline risk. And so the question here is, on the previous slide, I suggested that adverse events were going to be the same, and that's important, but we don't know whether adverse events are going to be the same in a high-risk population and a low-risk population, but this is just an example. So this was a meta-analysis of real patients, antihypertensive therapy, and they used different criteria to define cardiovascular risk than the Framingham score, but they did it their own way, and they had a low-risk group, 2 moderate-risk groups, and a high-risk group. And as what you can see here is that if you look over on the right side, if you look at those relative risks, they're all the same, regardless of the risk, the baseline risk. But if you look over at the absolute risks on the left, the absolute risk was higher in people with a high cardiovascular risk, and the risk was lower, substantially lower, in people with low cardiovascular risk. And if you look at the number needed to treat over 5 years to prevent a cardiovascular event, it was very large difference. So before I said that for high cardiovascular risks, we're now suggesting, high cardiovascular risk patients, we're now suggesting goal blood pressure of 120 to 125 if you use the automated machine, 125 to 130 if you're using standard methods. But for standard risk patients, we're recommending the usual goal. So if you use a standard cuff, less than 140/90. If you use an automated cuff, got to factor in the extra 5 millimeters of mercury. So if you're using the automated cuff, the goal blood pressure would be 135 instead of 140. All right. So in the future, so SHEP has already changed in 2016 and is now in agreement with what we say in up to date. Other major societies are going to be publishing soon. There's not going to be a JNC9. So NIH is done with JNC. They're now, US recommendations are going to be made by the American Heart Association, American College of Cardiology, and the American Society of Hypertension. So we don't know yet because they haven't published new guidelines. We don't know what their goals are going to be, but they may follow suit. And just like Canadians are already doing, there may be recommendations that we should be following people in the clinic using automated machines as opposed to the way that we're doing it most of the time now. Okay, so antihypertensive therapy. 58-year-old woman returns for follow-up of her hypertension, which you diagnosed 6 months ago. Since then, she's tried lifestyle interventions by modifying her diet, and she's trying to exercise. Her Framingham risk score is 3%. Her blood pressure is 148/92 using an automated oscillometric device. So blood pressure is elevated despite lifestyle modifications. So which of the following is the most appropriate next step to manage her hypertension? Prescribe one of the following: lisinopril, amlodipine, chlorthalidone, or indapamide. B, prescribe one of lisinopril, amlodipine, or hydrochlorothiazide. Or C, prescribe one of the following: metoprolol, chlorthalidone, or hydrochlorothiazide. What do you think? Okay, so just in case we run out of time, here are the Cliff's Notes. So sometimes there's a specific indication to either use a medication or to not use a medication. For example, in your patients with reduced ejection fraction using RAS blockers, or someone who just had an MI using beta blockers. But for most patients who are presenting to primary care without a specific indication for a medication, if you're going to prescribe monotherapy, use either an ACE or an ARB, or a long-acting dihydropyridine, or a thiazide diuretic. I should say a thiazide-like diuretic, as opposed to a thiazide-type diuretic. I'll talk about that in a second. So of these three, which are all good options for monotherapy, if your patient needs dual therapy, there is a trial which suggests that combining an ACE with a calcium channel blocker is better than combining an ACE with a diuretic. And so if, a lot of patients who you'll start on monotherapy will eventually need dual therapy. And if your optimal dual therapy is the combination of an ACE and a calcium channel blocker, then if it's all the same, then maybe start either the ACE or the calcium blocker as your initial monotherapy, and that way it becomes easier if the patient needs dual therapy to then go on and take the optimal combination. But that's not to say that diuretics are not a good option for patients who need monotherapy for their hypertension. And then if you need 3 drugs, all 3 of these are optimal. Now, if you're going to prescribe a diuretic, there is evidence, which I'm going to show you in a second, that thiazide-like diuretics, specifically chlorthalidone and indapamide, are more potent and are associated with better cardiovascular outcomes than a thiazide-type diuretic, such as hydrochlorothiazide. The problem here, of course, is formulary, cost, et cetera. And for patients that don't have insurance, or if chlorthalidone is not on your formulary, it becomes very difficult to use that instead of hydrochlorothiazide. And if you need a 4th drug, it's a mineralocorticoid receptor antagonist. And the other thing is to not combine an ACE inhibitor with an ARB. And I think I'm going to skip over some of those slides in the interest of time. So again, this is all hat. This is mono. These are 3 drugs that are compared with each other: chlorthalidone, amlodipine, lisinopril. This is the all hat trial. From this, there were rumors that chlorthalidone, not rumors, but there was a suggestion that the diuretic might actually be best because there was a reduction in heart failure events. But this was the primary endpoint, primary composite cardiovascular endpoint, and there was no difference with any of the drugs. And I should say that the heart failure endpoint, which appeared better with chlorthalidone than the other 2, the adjudicating committee that was deciding whether a patient in the trial had a heart failure outcome or didn't have a heart failure outcome was using peripheral edema as one of the qualifications for heart failure. So if you're admitted to the hospital and noted to have peripheral edema, you could be labeled as having heart failure by the adjudication committee. So it's not 100% clear that really chlorthalidone is going to prevent heart failure compared with the other drugs. So chlorthalidone and indapamide, which are thiazide-like diuretics, are more potent in blood pressure response than hydrochlorothiazide. So over on the left is a meta-analysis of chlorthalidone compared with hydrochlorothiazide, and over on the right is a meta-analysis of indapamide, which is used more in Europe, compared with hydrochlorothiazide, and they're more potent antihypertensive drugs. And this may result in what we see in a network meta-analysis. So a network meta-analysis, typical meta-analysis is you have 10 trials, for example, comparing A versus B, and you synthesize them all together. A network meta-analysis is where you have A versus C in this trial and B versus C in this trial, and because they have a common comparator, C, you're able to create indirect comparisons. And for these drugs, in chlorthalidone and hydrochlorothiazide, the network meta-analysis is the best we have because they have never been directly compared with each other in a trial of cardiovascular events. The ones I showed you on the previous slide were short-term studies on blood pressure. So in the network meta-analysis, chlorthalidone was associated with the lower risk of having cardiovascular events compared with hydrochlorothiazide. There are two large observational studies. One was significant, one was not significant, but basically they're in agreement with the network meta-analysis. Beta blockers, I'll go through this quickly, are associated with a higher risk of events when compared with other antihypertensive medications. So unless there was a specific indication, you wouldn't be using beta blockers primarily to treat hypertension. This is dual therapy. This is the ACCOMPLISH trial that came out in 2008 in the New England Journal, and what it shows is that combination of an ACE inhibitor with a long-acting calcium channel blocker, amlodipine, produced significant benefit compared with benazepril plus hydrochlorothiazide. And so some investigators, some experts use this to suggest that your optimal combination is going to be the ACE and the calcium channel blocker. Now the knock on this is that the diuretic that was used was hydrochlorothiazide. And so if you were to do this study again, you would combine benazepril with chlorthalidone and compare that to benazepril and amlodipine. So if you did that, maybe there wouldn't be a difference. But this is what the best we have right now for dual therapy versus dual therapy, and it suggests that the combination of the ACE and the calcium channel blocker might be better.